So this is the second to last session. This is a SAM session, so make sure that you get your SAM paperwork, okay? If you don't have that, you can quickly grab that from one of our helpful ACRO coordinators. So we have an all-star team here for breast. Anthony Dragan from MD Anderson Cooper University, he's a chair there. Jennifer Bellin, coming all the way from Dana-Farber in Boston. And I think we can see who those two people are going to be rooting for. And then we have Julia White, who is obviously a world-renowned expert in breast, who is at The Ohio State University. So we'll start first with Anthony Dragan.
Sort of did the Marco Rubio thing there for a second. Thank you so much, Parul. Thank you to Jennifer and Julia. It's an honor to be on a panel about breast cancer today, and thank you for the selection committee. I don't mean to increase the radius of unexpected offense-taking that the New England Patriots fans in the room may have, and that Dr. Lally so graciously started, but yeah. So we're going to go through this presentation today. The topic is pretty complex, but I'm going to keep it focused. I have no disclosures. This is with apologies to Jane Austen. The pride and I tried to be, use alliteration, but really it was off of this book here. So I'm going to run through some cases. These are cases for you to think about, okay? And for the Patriots fans in the audience, I made it multiple choice. And for the Patriots fans in the audience, I made it ungraded. We're not going to score this, okay? Nobody's going to ask you to stand up or anything like that. So for the first one, I just want you to think about these and write them down if you want. 37-year-old BRCA-negative patient, T1A, ERPR, infiltrating ductal carcinoma, HER2, oncotype 11, post-lumpectomy sentinel lymph node biopsy, negative margins, no adjuvant chemotherapy. Think about what you might do, okay? This is the second case. 58-year-old with a clinical T2N0 by FNA of an axillary lymph node staged up front prior to neoadjuvant chemotherapy. She's triple positive, so she gets neo, Herceptin, Perjeta chemotherapy, and lumpectomy, sentinel lymph node biopsy. She has a YPT1A N0 disease. Just food for thought. Case 3, a couple more choices. 62-year-old grade 1 pathologic stage T1B ERPR positive infiltrating lobular carcinoma with lumpectomy, sentinel lymph node biopsy, negative margins, no chemotherapy. A couple of additional ones. We have the hypofractionation conventional, partial breast irradiation, or observation no RT. Okay? And then a 78-year-old with a grade 3 pathologic stage T1C N0 triple negative infiltrating ductal carcinoma who undergoes lumpectomy, sentinel lymph node biopsy, negative margins, has 4 cycles of TC-based chemotherapy adjuvantly. Observation, conventional, whole breast hypofractionated, partial breast irradiation. Okay? Now, it's not like the Cracker Barrel thing where I'm tricking everybody and you can't win. I just want you to think about these cases, and as I go through, think about maybe how your perceptions are changed, or might be changed. This really is for this audience here. This is, and I'm assuming 2 things that this audience overwhelmingly agrees with. Number 1, that breast conservation therapy, conservative surgery with adjuvant radiation therapy is preferred for the vast majority of early stage patients. And number 2, that the rise of the use of elective mastectomy with immediate reconstruction and otherwise appropriate breast conservation candidates is troubling, and I would say anti-science. Now, what do I mean by these premises? Number 1, breast conservation is preferred. Well, it's been validated despite the very, very primitive medical environment and understanding of breast cancer at that time. That breast conservation eligibility, meaning stage migration, catching patients earlier and earlier in the process with digital mammography and MRI up front, is really the largest benefit of widespread screening, that breast conservation therapy is less toxic and more cost-effective than mastectomy when you add in reconstruction, and that there is some percolating evidence out there, albeit it's small, that breast conservation therapy with appropriate radiotherapy may actually be better than mastectomy. But I don't want to arbitrate that at this meeting, but it's suffice it to say there's some evidence. Elective mastectomies are troubling. What do we mean? The decision-making is largely based on fear and personal biases, both from the patients and the physicians. It negates nearly a half a century of accumulation of data and very brave patients who agree to be randomized from radical surgery onto more conservative surgery, which really couldn't be done today. It oftentimes there's some dubious interests, because if you're a surgeon and a plastic surgeon, you can open your own breast center together with very little overhead. There are newer techniques such as skin and nipple sparing mastectomy that are, by our standards, poorly validated, but have been integrated into practice. And oftentimes there's the worthless contralateral prophylactic mastectomy that's usually done for the medical indication of symmetry. So reconstruction confuses and oftentimes can compromise the oncology decision-making process. I think of myself and anybody else who practices in the MD Anderson network, where you have to inflate the tissue expander, and then you deflate it, and then you inflate it again, and it becomes all about the referral to this hokey pokey that we do with the tissue expander, and it's become all about that. So we say don't do it, right? All of us say, we want to improve and expand access to breast conservation. That means that we want to have radiation oncologists involved up front. We want surgeons to be breast focused and use core biopsy, not excisional biopsy, and use oncoplastic techniques, and don't do axillary dissections, do sentinel lymph node biopsies. And we want our med-oncs to be thoughtful and use neoadjuvant chemotherapy to downstage people and genomic testing to avoid chemotherapy. So in other words, the breast team should put their self-interest aside and favor the options that are more progressive and multidisciplinary and patient-centric. And of course, ensure a prompt referral to radiation oncology so that we can give everybody 50 gray to 50.4 gray in 25 to 28 fractions with a 5 to 8 fraction boost, right? After all, surgeons and med-oncs don't come to these meetings. They don't know what we do anyway. Conventional fractionation has worked just fine for 100 years, so if it ain't broke. I'm still waiting for the long-term data on hypofraction. I love this one. The data and guidelines for partial breast irradiation are too confusing. So, why am I here? Well, when the B06 trial was launched, my best friend growing up in high school's car rolled off the assembly line, and it was called Big Blue, and it was a Cadillac Coupe d'Elegance. But if someone saw you driving this car today, they wouldn't exactly think that you had it all figured out. So, my premise today is that hypofractionation is an emerging standard of care. Now, this is a busy slide, okay? And they told me the pointer only works on this screen and to keep close to the mic when I use the pointer. So, if we look here, everybody says Canadian fractionation. Oh, I'm going to give her Canadian fractionation. Oh, Canadian fraction. The Brits have 4 times the number of patients in their trials, longer-term data, and for the Patriots fans in the audience, they included premenopausal women and women who underwent chemotherapy. You may want to remember that for the sheet in front of you. They included the START-B trial, premenopausal women and women who had undergone chemotherapy, which the Canadians did not. I mean, they had a very homogeneous population, low-risk disease, postmenopausal patients. So people think, well, that's the population for hypofractionation. So, in the UK since 2012, 40 gray and 15 fractions in 3 weeks has been recommended for adjuvant radiation therapy for their health system. The National Institute for Clinical Excellence really does the evidence-based recommendations for the NHS, and they basically feel that there's no clinical rationale for excluding underrepresented subgroups in The application is because they'll always be underrepresented. They were underrepresented in the B06 trial when breast conservation was validated, premenopausal patients were. So they don't see the rationale for excluding those patients, that breast conservation or post-mastectomy, they use this fractionation scheme. They use it for DCIS, for systemic chemotherapy or premenopausal patients. And regional nodal irradiation is treated this way. So just to think about it, okay? As some of the things are, but you may say, well, didn't the Canadians say that high grade was a little bit dicey and, you know, they didn't know, and maybe you shouldn't do hypofractionation. But a meta-analysis from those Royal Marsden trials, START A and START B, showed that indeed, with more patients, they did not find a difference between high-grade and low-grade patients, stage for stage, for hypofractionation. What about the injury to the lung? Well, we all know that the lung is injured at doses much lower than we give, and that it's really a dose volume issue, so we can throw that one out. What about the heart? Well, there's no safe cardiac dose, so we have to use more anatomic or technical things to protect the heart, whether that's deep inspiration breath hold or prone breast radiation therapy. But if you don't believe me, the Canadians did a very large analysis of their people treated in their health system with 2,000 patients treated with hypofractionation, about 500, and they looked at cardiac events. It's kind of like nailing jello to the wall to figure out what the cardiac effects are with radiation, but they, suffice it to say, they had the same number of hospitalizations for cardiac morbidity in patients treated with left-sided breast cancers, regardless of the fractionation. And if we're using mean heart dose, we don't know exactly what we do. Everybody's using mean heart dose now for protocols and things. So the question is, mean heart dose is related to total dose and not necessarily to fractionation, because most of your mean heart doses comes from internal low energy scatter. So if that's the case, shouldn't a lower total dose with hypofractionation be maybe a little bit more advantageous? We don't know, but it's food for thought. What about brachial plexus injury? Well, this just came out in November, and this was about almost 1,000 patients, again, from the Royal Marsden Hospital and START trials with 10-year follow-up, and they found no difference in shoulder or arm symptoms between patients treated with hypofractionation or conventional fractionation, with one exception. Now, all those busyness on the START trials, they were all dose-finding studies, so there was, some of those fractionation schemes worked, some of them didn't. And the 3.3 times 13, which nobody advocates using, had worse shoulder stiffness and arm pain, and but they also had worse breast symptoms too. So, okay, on to partial breast irradiation. The early partial breast irradiation consensus statements are listed here, the ABS, ASBS, and then the JEC-ESTRO, pretty broad criteria. ACRO comes in 2009 and kind of consolidates them and makes them a little bit more confusing. With the categories based on how many patients were included in clinical trials, not necessarily outcomes, and there was a little bit of a chilling effect on the partial breast irradiation, especially brachytherapy industry. And then, of course, this was this past year, which was ASTRO 2.0, where they sort of broadened the criteria a little bit, made age, if age itself wasn't a factor as long as biological conditions were met. So just an update for the group on probably our longest term or best brachytherapy trials. First is the JEC-ESTRO randomized trial. This was published in The Lancet in 2016. Long-term data on patients, 1,300 patients randomized to receive either whole breast radiation, conventional fractionation, or partial breast using either HDR or pulse dose rate. They had some patients, the majority were small tumors, early stage, but they found no differences between the groups with regard to ipsilateral breast tumor recurrence or toxicity at a follow-up of 6 years. The ASBS registry data, the American Society of Breast Surgeons for the Mammoth Site, this was the last analysis of patients treated with the first-generation Mammocyte single lumen, again, 1,400 patients with a median follow-up of 5 years. They showed an ipsilateral breast tumor recurrence rate of just under 4%, which they found was a little bit worse for ER negative and for larger tumor size. But generally speaking, excellent cosmetic results, and infection being the issue. I prefer to move on to external beam partial breast irradiation because there's basically 3 trials that I look at for this that have been published in the last 5 years. The first one, the Florence trial, which is about 500 patients over the age of 40 up to T2 disease. About a quarter of them were ACRO 1.0 unsuitable, and they treated with a fractionation scheme that is not used very much in America, but is used in Europe. 30 gray and 5 fractions every other day for 2.5 weeks. And they found good results. Same recurrence rates. The acute toxicity rate was higher for conventional whole breast radiation. The late toxicity was higher, and cosmesis was better for the partial breast irradiation group. The RAPID trial, this gained a lot because a lot of attention. This is basically the similar fractionation, 38.5 gray and 10 fractions twice a day, which many of you are familiar with, the sort of RTOG fractionation technique. 2,100 patients randomized to receive either hypofractionation or conventional fractionation as the standard. And with a median follow-up of 3 years, they were reporting their toxicity, not their outcomes. This gained a lot of attention for the fact that APBI group had worse cosmetic outcomes assessed independently by patients and physicians and nurses. So for the Patriots fans in the crowd, you may want to look at your sheet and take a look and see if the RAPID trial pops out at you for that. So this is the trial I love, okay? And this is one that I didn't say it, but Ben Smith said it at ASTRO this year, that it was the most practice-changing breast radiation study in the last decade. It was a very pragmatic study. 2,000 patients randomized in Great Britain over the age of 50, T1, up to N1 disease. Whole breast radiation, 40 and 15, standard start B. Then they did this fancy schmancy thing where they tried to reduce the whole breast to 36 and do a simultaneous integrated boost to keep it at 40 for the lumpectomy cavity. And then the third arm was just once daily, 40 gray and 15 fractions, but instead of the whole breast, you're just treating partial breast once a day. Very pragmatic, mini conformal tangents, nothing special. Okay, and what they found that it was non-inferior at 5 years. And the cosmesis was better for partial breast. So since these are all Canadian patients, you're over 50, early stage disease, you may wonder if whole breast hypofractionation is now gone or going away. Because when I see somebody who's eligible for that, I say, well, why do I need to treat the whole breast when I can just treat them with the same fractionation scheme, partial breast? Something to think about. So in conclusion, look at that, and a little bit of time to spare. I'm out of Patriots jokes, so we'll conclude with these questions, okay? These aren't my statements, they're just questions. Is conventional fractionation our mastectomy? Are there similar biases at work here and self-interests in preserving its use? Is there resistance to using logic and reason to extrapolate the existing data to cover populations in whom we will never have dedicated randomized studies, or by the time that we do, we'll all be replaced by robots anyway, so it won't matter? Is conventional fractionation ultimately holding U.S. radiation oncology back? Now, what I mean that is it contributing to a ceiling of breast conservation candidates that we see? We don't see the denominator. The surgeons see the denominator. The medical oncologists do. The patient who walks into their office and says, I heard that I have to have 6 weeks of radiation and I'm not doing it, so I'm having a mastectomy. We've done population-based studies on this and shown that there are these large populations of women who are either unnecessarily getting a mastectomy, over-treatment, or getting the lumpectomy and not following up for the radiation, under-treatment. So is this contributing contributing to a ceiling there? And are we losing a seat at the table for meaningful clinical trials? All these clinical trials are being done by the Canadians and the British and the Europeans. Are we basically losing a seat because we can't accrue patients to hypofractionation trials in this country? I don't know. And are we losing an opportunity for lobbying and being proactive in terms of lobbying for incentivizing the use of this treatment? We know that there are quality metrics that ACRO is coming out with for the use of this, but have we lost or are we missing the boat where we could be out there advocating to the third-party payers that this is more cost-effective and gets people back to a better quality of life quicker than conventional fractionation? So with that, that was my food for thought, and look at that, 1 minute before time, Dr. Berry. So
Perfect.
Thank you.
All right. Dr. Bellin, why don't you hop on up? So our next speaker will be Dr. Bellin.
So my only disclaimer is I'm not a Patriots fan. I'm actually from Cleveland, so I do accept your sympathies after our perfect season this year. Yeah, it's always next year. All right, so I'm going to start out with the case as well. This is, I'm sure, something that at least that you see quite frequently, and this is our standard tumor board case. So the 38-year-old woman presents with a mass in the medial, slightly medial central left breast. The axilla was clinically negative. She gets a mammogram. It shows a 1.8 centimeter solid mass with no suspicious axillary lymph nodes either on imaging or on exam. She gets a core biopsy, which shows invasive ductal carcinoma, high grade, ER positive, PR positive, and HER2 negative. She undergoes breast-conserving surgery and sentinel node biopsy, and pathology shows high-grade invasive ductal carcinoma, just over 2 centimeters with LVI, and 1 out of 2 of the sentinel nodes contains a 1 centimeter focus of disease, and she gets an oncotype, which is 38. Her medical oncologist has recommended dose-dense ACT, followed by tamoxifen. So the local therapy questions: should she have a daxillary dissection, and what fields, what radiation, what fields? And I actually should, in deference to Dr. White, not say what fields should be treated, but what anatomic levels of the axilla and what anatomic sites should be treated. Okay, so we're all, I think, very familiar with Z11. The updated 10-year results looking at axillary dissection or not in patients with 1 to 2 positive axillary sentinel nodes show that there is excellent long-term control with no difference in local regional recurrence, disease-free, or overall survival between the groups that undergo dissection or not, and then now with a median follow-up of over 9 years. We also have the AMROS trial also addressing the surgical question of whether patients who have a positive node benefit from axillary dissection. So patients with clinical T1 or T2 and 0 disease who are node negative are not randomized. Patients who are node positive randomized to completion axillary dissection or axillary radiation. So these are the patient characteristics. You can see that about a quarter of the patients had high-grade disease. About 20%, just under 20% were treated with mastectomy. Most had some type of systemic therapy, and about 95% of patients only had 1 or 2 positive nodes. And this is taken from their paper showing you what the axillary field would look like, including the axilla and the supraclavicular region. And their long-term results show no statistically significant difference in axillary recurrence, disease-free survival, or overall survival, but an increase in the rate of lymphedema in women who are randomized to completion dissection versus axillary radiation. And this just shows you the disease-free survival and overall survival. So essentially superimposable survival curves. And if you look at the patient characteristics between the two studies, Z11 on the left, Amoros on the right, you can see that they're fairly similar. In the patients that go on and have a completion dissection, slightly more in the Amoros trial had additional positive nodes, but they're not that different. Similar rates of ER positivity and high-grade disease, similar tumor size and patient age. So there's definitely overlap in eligibility. So both of these indicate that completion dissection is not necessary for many, if not most, patients with 1 to 2 positive nodes. So we can argue whether all patients eligible for the trial should be treated, all patients eligible are the same as the average patient, but nonetheless, I think that has become generally accepted that most patients do not need a completion dissection. But what volume to radiate? So the breast alone, as was stated in Z11, breast and level 1 and part of level 2, as was done for many patients who were actually treated on Z11. More comprehensive radiation, breast plus level 1, 2, and 3, and the supraclavicular region, and all of that plus the internal mammary nodes. What's the correct answer? So we do have a little bit more data in the last few years to guide us here. This is Tim Whalen's paper from the New England Journal in 2015. So patients, all who had a completion dissection who were node positive, randomized to whole breast irradiation or whole breast plus regional nodal radiation. I should say that high-risk node negative patients were also included. So again, patients had to either be node positive or high-risk node negative, and this is how you were able to gain entry if you were node negative. So greater than 5 centimeters or greater than 2 centimeters and less than 10 nodes removed, and grade 3 or LVI or ER negative. So I hope I have the ands and ors correct there. I think I do. And about 10% of the patients got in, were enrolled based on high-risk node negative compared to node positive. Chemotherapy and or endocrine therapy was required. And these are the baseline characteristics. So again, about 10% of patients in both, and even in both arms, were node negative. And about 40% were high grade, about a quarter ER negative, and a very high percentage received adjuvant chemotherapy and or endocrine therapy, and about a quarter had a boost. So they're about 10% node negative, and about a quarter were high grade. And these are the 10-year results. So you can see that local regional recurrence was improved in patients who had nodal radiation compared to those who did not. Disease-free survival was also improved in patients randomized to nodal radiation, but there was no difference in overall survival. So this shows us the hazards based on subgroups. There was a benefit to node ER negative patients compared to ER positive patients, but the interaction term didn't reach significance. So the interaction of randomization and ER did not quite reach significance at 0.08. Adverse events, the rate of lymphedema was increased, the rate of radiation pneumonitis was increased, but very small in both arms, and no difference in major cardiac events, so you could argue maybe the follow-up is a little short for that. And I think these results are strengthened by the results by a very similar study from the ERTC, randomized patients with stage 1 to 3 disease, either node positive or node negative with medial central tumors. And this time, approximately 45% of patients were enrolled based on having the medial or central but node negative disease as opposed to being node positive. And again, the randomization was very similar, no nodal radiation or internal mammary and supraclavicular nodal radiation. And these are the patient characteristics. As opposed to MA20, approximately 24% of patients did have a mastectomy, as opposed to breast-conserving surgery, and 44% of patients were axillary node negative. Disease-free survival was improved in patients randomized to nodal radiation compared to no nodal radiation, although there was no difference, no statistically significant difference, didn't quite get there in terms of overall survival. This is the hazards for overall survival according to subgroups, and you can see that there was no subgroup that is an outlier, and that included patients with ER-negative disease, so they did not benefit more or less, at least statistically, from nodal radiation. There was also a benefit in the node-negative patients who were randomized and entered the trial based on the location of the tumor. And we also recently have the Danish experience, which I think is a really interesting study. It's a prospective cohort study. So this is not a randomized trial, but there was agreement as to how patients would be treated. So all patients were node positive, micrometastasis were excluded, and they had to be younger than age 70. All received paraclavicular and chest or breast radiation. Left-sided patients were treated without internal mammary node radiation, and right-sided patients were designated to have inclusion of the internal mammary nodes. I think it's actually kind of remarkable that there is enough organization to pull this off outside of a randomized trial. These are the patient and treatment characteristics. So about 2/3 patients had mastectomy, 1/3 breast conservation. Most were ER positive. The majority had 1 to 3 positive nodes, but you can see that about 1/4 had 4 to 9 positive nodes, and 15% were even higher risk, and about 1/4 had high-grade disease. And while not randomized, it does appear that there was a benefit from internal mammary radiation with improvements in overall survival, breast cancer mortality. Breast distant recurrence did not quite reach statistical significance. Now, I think we might ultimately be able to also use biologic information to help guide these treatment decisions. So I wanted to show you some retrospective data from Terry Mamounis looking at oncotype as it relates to local regional recurrence. So this is a study that I think has been very widely quoted, and you might be familiar with it. What he did was he looked back on patients enrolled in B28, which is a chemotherapy randomization, AC with or without the T. 1,000 patients who were taking tamoxifen with a recurrence score. So all patients older than 50 and less than 50 who are ER or PR positive received concurrent tamoxifen. The beauty of this was that patients it was relatively standard how the radiation fields were determined. Lumpectomy patients received radiation to the breast, but mastectomy patients were designated to not have radiation routinely. Median follow-up was 11 years. And what they found was that there was a breakdown in local regional recurrence by recurrence score. So patients with a higher recurrence score had a higher rate of local regional recurrence. Patients with a low recurrence score had a lower rate of local regional recurrence. And on multivariate analysis, you can see that recurrence score was as meaningful in determining risk of local regional recurrence as our very standard indicators, number of positive nodes and tumor size. So the NCIC, in collaboration both with the Alliance as well as other cooperative groups, have now initiated a randomized trial to try and look at whether patients with biologically low-risk tumors, as determined by oncotype, might also benefit from nodal radiation, and whether we can use the biologic information to help guide these treatment decisions. So the randomization is similar to that in B51, in that mastectomy patients randomized to radiation or not, and patients undergoing breast-conserving surgery all receive radiation to the breast and are randomized to nodal radiation or no nodal radiation. So I think we have multiple questions and still few answers. I think there's uncertainty about the relative benefit of internal mammary versus supraclavicular radiation. So both MA20 and the ERTC required both supraclavicular and internal mammary radiation. But does it make sense to treat the supraclavicular region alone in patients who have quote-unquote difficult anatomy, where treating the internal mammary nodes might increase their heart or lung metrics? I think as a purist, you'd say if you're going to quote a patient the benefit of nodal radiation based on MA20 or the ERTC trial, you want to treat those patients as it was done in the trial. But what about patients who have medial tumors that are axillary node negative? I think the benefit of supraclavicular in those patients is still unknown. Which subgroups are most likely to benefit? Patients with ER negative disease, patients with 1 positive node instead of 3 positive nodes. I think that still remains to be determined. And I think we have some uncertainty about the long-term risk of increased lung and possibly heart radiation. And this, I'm just guessing or hypothesizing that it's possible this could even extend beyond the short-term risk of an increase in V20. So what happens to the lady who's now 70 years old and had more of her lung treated and now has some heart disease for reasons unrelated to the radiation? Will she have more cardiovascular problems? That's not data-based, just a concern. I think we have uncertainty about the role of oncotype and other biologic predictors of response in guiding local therapy. We have really interesting and provocative retrospective data, but I think it'll be great to see how that plays out prospectively. And I think there's also a big unknown about the role of more extended radiation as systemic therapy improves, particularly with anti-HER2 therapy. So as patients get not just Herceptin, but other anti-HER2 agents, will the role of radiation potentially lessen as those patients have improved local regional control? I think that's an unknown at this point. So our patient would have been eligible for Z11, but I didn't get into, in the interest of time, there was uncertainty in the radiation fields in Z11, which was really a surgical question. But based on her risk features, including the high-grade disease, the nodal ratio, her age, I would feel uncomfortable treating just the breast. I'm swayed by MA20, the ERTC, and the Danish trial in this young woman who had high-grade disease, which is LVI positive, medial located, and I would treat comprehensively, including the internal mammary and levels 1, 2, and 3 in the supraclavicular region. So I was asked to just finish with a few points about treatment planning. So I would target the lumpectomy site as well as the breast, level 1, 2, 3, and the supraclavicular region, as she did not have a dissection, and the internal mammary nodes in the upper 3 intercostal spaces. Organs at risk: the heart, the lung, the thyroid, contralateral breast. So lumpectomy site GTV would be contoured, CTV expansion, PTV, and the PTV eval, which is shaved off of the skin. Also the breast CTV. And then the IMN, CTV, and PTV. So this expansion is not posteriorly into the lung to decrease lung dose. The R2G also specifies that the PTV isn't expanded into the sternum, again, to decrease the lung volume. And there's axillary and supraclavicular CTV. So I would use DIBH when I do her planning. We do that for all left-sided patients, at least we look at it, and for all right-sided patients when I'm including the internal mammary nodes. We would use multiple subfields, field and field, to maximize homogeneity. I would typically use partially wide tangents to include the internal mammary nodes, so it would block inferiorly below the first three intercostal spaces to minimize heart and lung. Occasionally, in patients with particularly difficult anatomy, would use a true IMRT approach. I would treat the breast and the internal mammary nodes with to 50 gray, followed by a 10 gray cone down to the lumpectomy site, and I would treat the nodes also to 50 gray. In my practice, we're not routinely using hypofractionation to the lymph nodes outside of a trial. Thank you very much.
All right, that was an absolutely brilliant talk. Now we'll finish off with Dr. White for recurrent and metastatic breast cancer.
Good afternoon, good morning. So this is actually, we're going to lead from where we know lots of data. You heard two talks about where we have thousands of patients in randomized trials, right? Now we're going to go to something where we have the data is yet to come, and we're looking at using radiation in a more novel way. So I'm not going to present a case. We're just going to talk about. This is more about opening our minds to what's coming down the pike. I have to say, we have to give credit to our fearless leader here with the most creative titles of talks I've ever seen at any meeting. So I'm going to talk about in-breast recurrence after breast-conserving therapy, which I think is really going to become an increasingly important issue in oligometastatic breast cancer, two relatively novel areas where we're using radiation. So let's talk about in-breast recurrence. These are patients who've undergone standard lumpectomy and radiation therapy, whole breast radiation therapy. And we know that, as we've heard in prior talks, the rates of in-breast recurrence, or all local regional recurrence, has really gone down over time because we've gotten better screening. More patients are screened. We find smaller tumors. Surgeons have gotten better with negative margins. We have better drug agents, so for a lot of reasons. Overall, though, you'll see the median time to failure stays about the same. It's about 4 years. But the standard treatment for in-breast recurrence has been mastectomy. And quite frankly, the standard treatment for in-breast recurrence without radiation is mastectomy. So it's just a knee-jerk reaction that it's mastectomy. So and the question now becomes, as we find smaller recurrences and we have more novel radiotherapy, is second breast-conserving treatment feasible and safe? Now, this is the table for mastectomy for treatment. This is the standard of care. And these are select, these are all retrospective, and they go over time. They're put together by their treatment era. And you can see overall that mastectomy isn't foolproof for this problem, right? That you see secondary local regional recurrences about anywhere on average about 15 to 20% of the time with mastectomy alone. So that raises the question is, can you do less than mastectomy? What are the variables associated with poor prognosis after treatment of IVR with mastectomy? Initial primary with node-positive disease. Women who have node-positive disease and then get a local regional recurrence, that's very serious. And it has to do with their node-positive disease more than their local regional recurrence. Their likelihood of distant metastasis is very high. A short time to in-breast recurrence is another one. So a short disease-free interval, ER-negative disease, high proliferation rate regardless of subtype, and extensive lymphovascular invasion in the recurrence tissue. But then how do we do? Let's say if you want something less than mastectomy and you want to preserve your breast. These are motivated women who want this. And this shows there's very little data for second lumpectomy for treatment of IBR alone. There's a lot of little trials, 25 here, 30 there. We love to publish those in radiation. And you can see, initially it looked quite favorable in this publication from Yale quite a while ago. But in larger multi-institutional retrospective studies from Japan and the European Institute of Oncology, Milan, you can see that the secondary likelihood of local regional recurrence is about 20 to 25%. In all of these studies, there were invasive breast recurrences. And again, you can see the risk factors for second IBR. So should that be concerning? Well, this publication came out from UC Davis in 2008, where again, I really don't like SEER outcome data, because SEER is meant for medical trends. It's really not meant to show outcome. But I think when you have rare instances and rare tumors, I think it's very helpful, and I think it's helpful here. So they looked at SEER data from 1988 to 2004, and it speaks to how uncommon it is when they only find 747 of them over that big time period in SEER. But nevertheless, they looked at who was treated with mastectomy and who was treated with lumpectomy alone for in-breast recurrence. And you can see there that they did show a difference in survival. If you had lumpectomy alone, you did better with the mastectomy. Now, they did do a sort of subset analysis where they looked at good risk patients, what we see, estrogen receptor positives, T1 tumors, N0NX. And in that population, there was not a significant difference in mastectomy versus lumpectomy. This data is fortified by this data. And this is from, again, the Japanese Breast Cancer Society. It's a 8-institution coalition. And they did another retrospective cohort study looking at patients, but they had 271 IBRs. Second lumpectomy was done in more of them than mastectomy, and the median follow-up was 55 months. And here they tried to control the variables. We think that propensity analysis erases all bias, but it doesn't. But it does a pretty good job of controlling variables when you compare one group to the other. And here what you see is that when you matched grade and age and stage at diagnosis, there was no significant differences by surgery type. And this really let us, people start thinking, well, what can we do with new technology like partial breast irradiation to see if we can get better local regional control following lumpectomy alone in certain subsets. And this is a study that came out from the ACRO group, and again, multi-center, 8 European radiation centers, it's retrospective. But again, they had a pretty good number of IBRs over a long period of time, and they all get brachytherapy. So they got partial breast re-irradiation using brachytherapy techniques. But importantly, they use brachytherapy techniques consistent with what they did for upfront partial breast irradiation. For the most part, partial breast irradiation, APBI in this country is defined as less than usually 5 to 8 day delivery in terms of delivering it. So the mean size of these tumors were pretty small. 73% of them were ER/PR positive. So you get the sense that retrospectively, patients were really chosen to be good actors for this type of therapy over this time period. And here you see with a median follow-up of 4 years, the second IBR rate now is 4.1%, much better than after lumpectomy alone or mastectomy. And the overall survival following is actually very good. So this really led us within NRG Oncology, or then RTOG, to really question is, what does this look like prospectively? All the data is retrospective. It comes over a long period of time. Could we use what we know about partial breast irradiation to develop partial breast re-irradiation? And we really do make it different, because re-irradiation is done differently than APBI. This is not APBI in terms of getting it done within 5 to 8 days. So our primary objective was really adverse event control. It was really feasibility and safety. That was our primary. And then secondary was in-breast control, freedom from mastectomy and adverse events after 1 year. I'm just going to quickly go through the eligibility. The eligibility was pretty wide open. You had to be a year out from treatment. Your tumor size, remember, because we knew we were doing partial breast, you have to have a target you can hit with treating less than 30% of the breast. That's the key with partial breast irradiation, right? You can't treat 40% of the breast and say, because I only treated part of the breast, it's partial breast. You really have to keep it less than about 30% of the breast. So pathologic tumor size was less than 3 centimeters. You can see, and they had to be, you had to be able to see the target. We should be able to see the target in order to do partial breast irradiation. And this is what they did. We did 3D conformal external beam. It was all 3D CRT, and a very different fractionation than we use for APBI. So partial breast re-irradiation borrowed the head and neck fractionation and did this over 3 weeks with 1.5 BID because of in the re-irradiated setting. But the target volumes look exactly the same. In fact, this was what was in the protocol, and that looks familiar to you if you put patients on B390413. That's because it's the same image. So the targets were all the same. And this is how we recruited. 34 institutions accrued about 65 patients over 3 years' time. And we had 7 patients who were ineligible, mostly for administrative reasons, not that there was anything else going on with them. But we follow rules. In clinical trials, we follow rules so we get good outcomes. And here's the patient characteristics. What you're going to see is that 90% of them were over age 50. They were ductal patients mostly. Importantly, 40% of them were DCIS recurrence, not invasive recurrences, and about 3/4 were ER positive. And this is the 1-year data. Here's our primary endpoint. And I think all of us were really worried about this because you were re-irradiating in breast, and this was the first re-irradiation prospective breast trial. But we were pleased to see that only one patient had a grade 3 toxicity by 1 year reported. And then it was not uncommon to have a grade 1. That was pretty common in grade 2. So this was really heartening. But I think when we reported our secondary endpoint, and this manuscript is hopefully going to be out the door soon, I just saw the most recent version, what was encouraging to see is a median follow-up of 3.6 years. Our in-breast recurrence was 3.7%, and only 4 women had lost their breast. So 95% breast conservation rate with a nearly 97% cancer control rate. So we really thought that this was quite encouraging. So what's the summary? That I think for now, second breast conservation for IBR after whole breast RT is safe and effective for cases able to undergo partial breast reirradiation. Lumpectomy alone should be used cautiously for salvage for invasive recurrences. I think the jury is still out for DCIS recurrences. The unfortunate thing about this, and I'm going to be really clear, is women who come for breast preservation want breast preservation. And now as we look at de-escalating radiotherapy, we have to remember that that's an important endpoint. Whenever you don't use radiation, you're going to have more recurrences and more women are at risk for losing their breasts. So we have to make sure that we understand how to salvage patients. I think it's one of the most important things in our field going forward. And so I think this is nice in whole breast radiation, but for DCIS, lumpectomy alone might be fairly good still for after whole breast radiotherapy. We just don't know. There's absolutely very little data available for it. Mastectomy is still indicated for many women with invasive breast recurrence, but it shouldn't be the knee-jerk only treatment. So I want to move on to oligometastatic breast cancer. And here it's exciting. We all love SBRT. We all love these things that are very technically based and for which we get great reimbursement on. It's just a win-win for all of us, isn't it? So, but the reality is, can it outprove the outcome of disease? We know we can hit a target, and we know that cancer control is good in the target. I think we all agree on that. But can we change the outcome, the systemic outcome of a target? So we know that there's improved survival in metastatic breast cancer over time. We know that long-term now, that tail of the curve in metastatic breast cancer is longer and longer. And that's really because of widespread availability of modern systemic therapies. We also find patients sooner. It's that lead time bias because we find something on a very sensitive scan and it's there longer. Maybe the patient's really not living longer. And that's a question as well. So the question is there really a potential curable subset? So this was a editorial written by George Sledge, who we all really respect in breast cancer therapy. And he really put together this really nice editorial asking some really key questions. Long-term disease-free survival occurs. While these are few, it suggests that possibility of cure in metastatic breast cancer. And if some patients are cured, might we not cure more? And the things that George Sledge cited as evidence that cure is feeble is this. This is from the TAID. Adjuvant therapy cures micrometastatic disease. We know when we give women adjuvant chemotherapy, what we think after a curative surgery, more women live, and that tells us that we are eradicating microscopic distant metastases or cancer cell wannabes. Adjuvant therapy after isolated local regional recurrence improves survival. Chemotherapy for overt metastatic disease improves long-term survivors and exceptional responses with novel agents. But also, treatment of low-volume metastatic disease with surgery and radiation can produce long-term survivors. Now, that's the debatable part of it, quite frankly. So this is low volume or oligometastatic breast cancer associated with improved outcomes relative to more widespread involvement. This is what we know. If you have fewer mets, this is not just true of breast cancer, this is true in most other cancers. Lower volume disease, you do better than higher volume disease in most cases. Limited sites of metastasis involvement makes local therapy feasible. So again, we're really good as if we can hit it, if we can target it, we can hit it. And clinical outcomes appear improved by local therapy. The problem is it's unclear where better outcome reflects selection of patients with good performance status, or is there really a true effect of what we're doing? And that's what's really unknown. So we know from metastectomy, I'm just going to fly through this because this is all data we all probably know, that this is the largest lung metastectomy trial. It's very old. It's 15 years old, or now 16 years old. But it is a good example of how very retrospectively going back and saying when you could get a resection and when you could get an RO resection down to complete excision, these women appear to have a longer, appear to live longer. What we don't know, though, is would these people have lived longer without the resection? Because you have to be pretty healthy to get this resection, right? You have to be in pretty good shape all around. But the median survival is undeniably longer than you would expect in someone with visceral metastases from breast cancer. How about liver resection, breast cancer metastases? Again, these are all retrospective, highly selected patients, less than 1% of metastatic breast cancer, and the median survival range was 27 to 63 months. And the 5-year survival is impressive. The question is, did these patients, did the intervention benefit, or did they get the intervention because they were in good shape? And you see that here. So how about stereotactic body radiotherapy? I don't need to tell this crowd. We all, I think, hands down, when you compare metastectomy to SBRT, SBRT is non-invasive. There's no surgical side effects. You get them back to their systemic therapy faster, which is of prime importance. And there's more anatomical sites that are amenable to intervention. But, and here's the data on SBRT, and I haven't updated this slide, but there's probably 5 more or 6 more good retrospective studies, but they are all retrospective. They're mostly solitary sites, and in fact, if you go through each of these studies, less than 10% are more than one site. And they show like the metastectomy data, they show very good data. And one in particular, the Milano study from University of Rochester, they really looked at breast cancer specific patients. And they had 40 metastatic breast cancer patients, they used curative intensive doses, this is retrospective, however. And when they looked at their breast cancer patients, you can see really phenomenal, I mean, these are really impressive overall survivals and progression-free survivals. Based on data like this, we are seeing an increased use of SBRT for oligometastatic breast cancer. And in fact, just a couple years ago, when a survey was done here in North America and Europe, we see that nearly 61% of radiation oncologists who responded to survey were using it routinely in asymptomatic oligometastatic breast cancer, which to me is stunning. So this really is what led us up to Energy BR002. This is our ongoing phase 2 randomized into a 3 trial of ablative radiation therapy. Here are the arms. You can have up to less than 4 metastases. If you have liver or a mediastinal cervical location, it's still just 2 metastases until we finish BR001, which will close in 3 months. You can see our stratification. Arm 1 is standard systemic therapy with appropriate local, palliative local regional metastasis-specific treatment. And then Arm 2 is total ablation of all metastases by surgery or SBRT. We're really asking to do, we're looking for a big effect. So the phase 2R portion, we're trying to improve PFS from 10.5 to 19 months, a hazard ratio of 0.55. It's a big improvement. And then it will roll over to our phase 3 study, which needs 246 additional. And here we're looking to improve overall survival from 28% to 42.5%. So again, big effects we're looking for. Pathologic, here's our eligibility. Again, less than 4 metastases. It has to be less than 2 in the liver or mediastinal or cervical, pending BR001. Local regional disease has to be controlled. They have to be amenable to SBRT. All the disease sites have to be amenable to SBRT or resection. The individual metastases has to be rational for SBRT, so we have put 5 on that, and you have to have good performance status. And ineligibility, as you would expect, seen here. So the thing that's unique about BR002 is these are the so-called curative doses. It took us over 3 years to get everybody within Energy to agree on these doses. I'm not kidding. Because everybody who does SBRT, it's like they're artistes. They all want to do their own doses and what they've proven in their retrospective studies. So, but this is it, and you can say they're wrong. And God knows I've listened to hours of conference calls with everybody saying that everyone else was wrong. So, but the lung peripheral dose, lung central, the idea is to get it to, you're not just trying to take care of the MET, you're trying to ablate it. You're trying to equate it to an RO resection. So the doses are, we've gotten criticism, we get criticism both ways, they're too high and they're too low, but the doses are often a little bit higher than you would just use for a simple metastatic SBRT. So there's local treatment on both arms. In arm one, patients get their drug therapies, but you're also going to give them appropriate palliative surgery or radiation when necessary. And the difference is arm two, all the metastatic sites get ablated. So there's minimal disruption to systemic therapy. I think this is a trial for which we as radiation oncologists often don't see them because they're in the medical oncology department only. And so we like to reassure our medical oncologists that it's a systemic therapy friendly trial. And so in summary, SBRT use is common for metastatic disease. I think it's very common for metastatic disease. But I would remind you that it is unknown whether SBRT or resection changes outcome for asymptomatic metastatic disease. It is unknown. It is important not to expose metastatic patients to unnecessary tissue and financial toxicity. So what are the anticipated outcomes of this clinical trial? If ablative therapy of all metastases improves OS when added to standard systemic therapy, it's a major paradigm shift. It is a major paradigm shift. If ablative therapy of all metastases does not improve overall survival when added to standard systemic therapy, then off-protocol use of SBRT stops, and we reduce unnecessary tissue and financial toxicities to patients who are not going to live anyways. I think it's a very important question, and I really thank you for your time this morning.
Well, that was an absolutely delightful talk, and the breast team has probably done the best in keeping with their time, so we have some time for questions. All right, who wants a little microphone? Okay.
There you go.
Okay. Is it on? Are we?
Yeah, just
It's
begin.
on? Yeah, okay. Thanks. It's a really excellent panel discussion. I really appreciate this. I know there's topics across the board that time doesn't allow us to touch on, but I'm just curious about the feelings on a patient axillary dissection after neoadjuvant treatment. Obviously, the Alliance and RTOG trials are looking at the cases where patients present as node positive. But in patients who present clinically node negative and then after neoadjuvant have a positive sentinel node, there's not a lot of guidance in there in terms of the axillary dissection. In our practice, we're still doing the axillary dissection, particularly if they wouldn't have met sort of the 1071 criteria for low risk of additional nodes positive. But I am curious about how you all are approaching that in your practice, and even the kind of even grayer area of patients who've had neoadjuvant hormone therapy and end up with a positive node.
So I think that's a great question. And I think that at one time the trials were going to be amended for that, because the reality is if it's there after neoadjuvant chemotherapy, it was there before neoadjuvant chemotherapy. But this is the whole thing with writing trials, is you try to think of everything up front, and we want to make sure that we're getting good information out of it. But I think all of us would probably say that with a positive node, after your best drug therapy, you need regional nodal. And whether the I still think for even this case, the A11202 trial will help figure it out. Because if you're giving radiation anyways, then it may be that the dissection's not necessary. I would say that what makes me reassured in these cases is that the sentinel node, they kind of followed what you see in the Sentina trial for sentinel node after neoadjuvant chemotherapy, that I would feel more assured if there were 3 nodes out and 2 of them were negative or something, or that they did dual tracer. That would make me feel more comfortable with no axillary dissection. But we work with 6 surgeons, and I'm telling you, each surgeon has their own belief system on this, and so you and I could debate it till the cows come home, but I actually think it will be answered by A11202. I'm sorry they're not eligible, but it's just the foibles of putting together a trial.
Okay. Dr. Horowitz?
Question regarding how you follow your patients after APBI. There's a very recent study out of MD Anderson showing that maybe a quarter of patients who get brachytherapy have a subsequent breast biopsy. And I'm wondering if we need to augment our screening post-therapy.
I think, I don't know what happens at MD Anderson, but that's outside of what we saw in 95-17. So I think some institutions are better at technologies and some are not. Not anything for one institution or another. So I would be cautious about that. So I know that having worked a lot with single entry brachytherapy devices, you can see a rim of, like an eggshell rim of calcifications, but I think that really has to do with comfort of your imagers with knowing that technology, and I would bet over time those second biopsy rates would decrease. With imaging and with things like tomotherapy, with the minimal 3D reconstruction mammograms. But I just wanted to say I respect that that's what happened at that single institution, but across the board, that's not generally what's being seen.
Dr. Dragan?
Yeah, there you go.
We did a study looking, just following the radiographic appearance after APBI, just showing that in patients who we had long-term follow-up and knew they didn't have a recurrence, there were not infrequently fibrotic changes that were potentially concerning, but when we followed them, they didn't recur, with the benefit of time. So I think you have to just be very careful about overly aggressive interventions.
I agree with both of those. The only thing I would add is that the majority of these patients are coming from somewhere to a specialty center to get treated and then going back to wherever they came from. They may be involved with community breast imagers that aren't familiar with some of these changes too. So as far as anything I do, I don't have a magic wand, but I try to get them to come and get their breast imaging follow-up at our center when they're coming for routine follow-up as well. So it's...
Okay, great. Next.
Jessica Schuster from University of Wisconsin. I have two questions. One first directed to Dr. White. In practicing in the community, in looking at patients with recurrence, is there a practical piece of literature or suggestion in engaging breast surgeons in doing repeat lumpectomy?
Yeah, there's a, I don't know if this is on. I have this booming voice anyways. But there's actually an Austrian surgeon, and someone here is going to correct me. Felix Seldemeyer, is that his name? Did I get that wrong or right? He's a very senior guy. He's even older than I am. He wrote a paper, a nice review paper on it, going through all the different things. Because the studies that I tell you, they're either brachytherapy or they're, we did 3D CRT. But he does a really nice job. And I think there's some other good review papers on it. And I think it really comes down to a lot of biology. These are the patients who have especially the patients who have a long time to failure, a long disease-free interval, and who have small lesions. I think that those are the ones that I think you do incremental improvements. So even in my own practice, getting the surgeons to even send those patients to us has been a fight. But it's usually patient-driven. The woman really wants to keep her breast. She's 10 years out from her breast conservation. And I also think, I want to be clear again, I don't think we know that you need the reirradiation portion for a DCIS recurrence. So I think at least getting this, just working with your surgeons to try to get to see the DCIS recurrence and anything less than 10 millimeter ER positive, more than a few years out. That's where we started. I can't tell, it's taken us a while to get them to even send them though.
Julia, how do your surgeons handle the axilla in the setting of, say, a prior sentinel node at the time of the initial surgery and now with a T1 recurrence in the breast?
I think that, as you know, this is now going outside of how you salvage them. This is also an issue for patients who go on to get mastectomy. I think they attempt a second sentinel node in everybody. We used to have this black and white rules of who could get a sentinel node. You remember when it first came out? If you had this, you couldn't get it. And I think that's all out of the water. They just they try to get a sentinel node. But for instance, in 1014 in the invasive cancers, more than 30% of patients did not have any other additional nodes taken out because there weren't any on sentinel nodes and they already had a dissection. So what are you going to take out? And if you go and read the literature, you'll see that quite a bit, is that there is no additional axillary disease. We did require restaging in all the patients who went on this trial. And I'll tell you, we got tons of pushback on it because people didn't think we should restage. But because you couldn't do a dissection, we just felt it was necessary to do. I don't know if that helps you.
No, that does. Thank you very much.
And what's your second question?
Second question is directed to Dr. Bellin. Is there anyone in your practice currently that you are utilizing the Oncotype DX data to not give radiation? Or are we not there yet with the literature?
In the breast conservation setting?
Correct. Or in the post-mastectomy setting. I think that's the post-mastectomy setting is in sometimes where I'm getting a little bit of referencing to the data that you presented.
Yeah. So I will say, just to start off, in the breast conservation setting, outside of a trial, and the only one I'm aware of in the States is Reshma Jaxi's, the IDEA trial, that'll give us ultimately.
You have a trial.
But it's not using, yes, but it's not using Oncotype. We have a trial using PAM50, but similar. But outside of a trial, I would say I would not use that data in the breast conservation setting. In the mastectomy setting, I would say that, I'm eagerly looking forward to enrolling on MA39, which is going to use Oncotype in patients with positive nodes. Outside of that, I will tell you honestly, I have never ordered an Oncotype to help me with mastectomy decision-making. I look at it in gray areas based on the retrospective data we have. We also have nice data from SWOG as one of many factors.
Okay. Next question.
Hi, I'm Jonathan Strauss from Chicago. Thanks for these great talks. I have a quick partial breast irradiation question. I know what whole breast radiation is, but partial breast seems to be a kind of mixed bag of techniques that treat sometimes a large portion of the breast, sometimes a smaller portion. To what extent, if we look at the volumes in import low, they were pretty big. If you look at IORT techniques, they're fairly small. To what extent do we feel comfortable extrapolating from data from trials that treated relatively larger portions of the breast to techniques that treated relatively smaller portions?
Anthony, do you want to go?
I had a professor in medical school who was an internal medicine professor, and we were seeing somebody with rheumatoid arthritis, and he said, "Are you a lumper or a splitter?" They're all like, lupus and rheumatoid arthritis, and I'm a lumper. I treat them all the same way. And the question is it fair to do that with partial breast? If you look at the dosimetry of a single catheter mammocyte versus a multi-catheter, and where the hot spots are, and how deep the dose goes, and things like IORT, I think it's going to be very, very difficult to see. Dr. White's in charge of kind of, sort of processing and helping us all digest whatever comes out of B39 in those three different groups that come out of there. There's going to be a lot of interesting data because there's going to be some differences there, and whether the study's powered enough to detect them or not. But I think it's really interesting. It really is. But all these things are sort of like flowers all blooming all over the place, and I think that there are some patients where you could pick, that flower for that particular patient or not. I mean, patients have a rough time with BID schedules. I mean, they just do. So I like the import low because I like that came out because it took the different dosimetry and dosing completely out of the question, and it kept it as a single fraction. So I think it's really, an interesting thing that's evolving here, but that's...
I think it's hard to make sense of things when you don't put, I think it's really hard to make sense of things when you don't put categories on it. And you can't answer questions. I don't know if my mic is on.
Yes.
You can't answer questions unless you put some definitions, or you will see grays everywhere, right? So there always will be grays, but you need to categorize things to know. So within the United States, accelerated partial breast irradiation is less than a third of the breast. And that means people can have very small tumors and get very small things like IORT if they're small-breasted, but the same disease might not, if they're large-breasted, but if they're small-breasted, it might not work in them because it's just not feasible, right? So, and why is 30% picked? Because the reality is the larger the volume goes up, the more likely you are going to have toxicity. That's just the way it works. So that is what we categorize. I respect that you can like the 3-week regimen, but the whole idea of APBI, what's the rationale? Is to make it a more convenient radiotherapy. And so we have stated that accelerated partial breast irradiation should be delivered within 5 to 8 days. So things like IORT, everything you've seen on the 30 million single institution retrospective studies. There are 17 randomized trials that have over 14,000 women in it. They all follow that definition. Okay, so there's that definition. You can interpret it, whichever way you want, but that's the definition. The Livy fractionation from IMRT was established by Silvia Formenti, first when she was in California, and then when she was at NYU. I think that's the fractionation we'll go to, quite frankly. They had better cosmesis in the PBI arm. So the thing about IORT, where it doesn't fit into it yet, is it might be the right volume for the right patient. You just don't know because of the pathology issue, and I think that'll get sorted out. So for me, partial breast irradiation, what we need to figure out is on a biological basis, which cancers is it okay to just treat a third of the breast versus not. And once we find that, I totally agree. There's so much that all these 17 randomized trials cannot address. They cannot address what's the best fractionation, what's the best technology, but in reality, a gray is a gray is a gray is a gray, and how you deliver it there is important in terms of your therapeutic ratio, and there will be a lot of opportunities for a lot of very clever toxicity trials going forward once we determine biologically treating less than a third of the breast is equivalent in all disease, all types of breast cancer subtypes to the other arm. So I don't know if that addresses it, but at least for the 14,000 women on randomized trials in Europe, the United States, and in Canada, it's less than a third of the breast.
Perfect. One last question. Oh, sorry, the blue football.
Hello?
Yes.
Yeah, great. And this is a little bit more of a comment. I'm now at Banner MD Anderson, but prior to this, I was the head at Vancouver. So it's interesting the terminology we use here, that we keep calling it hypofractionated. But when I arrived in Vancouver from Buffalo, what I learned was they've been treating 4250 in 16 fractions for 25 years. That was the normal fractionation. They only put the 50 gray fractionation at 1.8s because Evo had gone to Harvard and done a fellowship for a while, came back, so it was a little in vogue thing to do that for a while, but everybody pretty quickly went back to 4250 and 16. So, and that's including the larger fields. It wasn't just the breast. So
And it included the supraclav fossa and whatnot, yeah.
Yeah,
So
and
that's
so the
pretty
way
well,
they prescribe dose
yeah.
slightly differently, that's raised, that we're gonna do our trials, but it's not something new.
Yeah.
Something
Anthony,
done
do
for
you wanna make a
25
comment?
years. It's a long history through Canada, and now we're testing it to convince ourselves with the way we prescribe dose. Is it a reasonable therapy? It's just interesting history.
It is,
Yeah.
and the whole fractionation thing came out of a class action lawsuit in the United Kingdom over this fractionation. And it had nothing to do with the fractionation, it was how the radiation was delivered, where they were giving the PAB in large fractions. In fact, I hate the whole idea of we say fields and not targets, but back then that's what they did fields. And the risk of brachioplexiopathies went skyrocketed, and there was a class action lawsuit that the providers lost, quite frankly. And that really is what solidified I think the 1.8 to 2 gray. And 1.8 versus 2 gray was just whether you were an SABP believer or not. So it's interesting, but you're right. It's mostly about differences in health policies in institutions, and it's now good to see it all become unified.
Why don't you just say one last thing on that?
My talk was really to provoke a little bit of that in the United States. I feel like you're exactly right, that this is not an issue for most places, but we have it still as an issue here. And my talk is not to say that everybody should be treated with hypofractionation like we do in other. I'm trying to nudge the people who are still looking at a 57-year-old with a T1B ER positive tumor and saying, oh, well, she's a little bit large-breasted, or she's got chemotherapy, so I'm going to go with conventional fractionation. It's to sort of say, ACRO and choosing wisely has opened up the door. I think it's a good discussion to have, and I think we need to see where the field is going. And if it truly is radiobiologically more effective, which is what I know a lot of the British studies are looking at now, to see if those curves diverge, if you can lump and see if those curves diverge and say that there's a radiobiological advantage to hypofractionation, then things are really going to get interesting.